It is October 1976. You are deep in the equatorial rainforest of northern Zaire.
Right, which is just a completely remote, intense environment.
Yeah, exactly. You're standing inside this rural Belgian Catholic mission hospital. It's in the village called Yambuku. And the environment around you is just, I mean, it is one of absolute terrifying chaos.
Terrifying is almost an understatement here.
Seriously. Patients who walked into the clinic just days ago complaining of, a simple headache and a fever, they are now bleeding profusely from their eyes, their gums, their injection sites.
It's a complete system collapse.
And it gets worse. The local Zairian nurses, the Belgian missionary sisters who run the wards, the very people trying to heal the sick, they are falling violently ill.
Yeah.
No one knows what is happening. The antimalarials aren't working. The antibiotics are completely useless.
Because they're fighting something totally unknown.
Right. But what makes this scene truly chilling isn't just the sheer speed of the mortality. It's this horrific realization dawning on the medical staff. The hospital itself, specifically the glass syringes they are reusing to administer vitamins and basic medicines, that is the very murder weapon.
Yeah, it's amplifying this invisible killer. The virus was moving with this brutal mechanical efficiency through the very tools of modern medicine.
It's just devastating.
And it was also moving with a tragic human efficiency through the compassion of the caregivers. I mean, when a pathogen emerges from a deep forest ecosystem with that kind of violence, it fundamentally breaks the diagnostic landscape.
You're just flying blind.
Exactly. You are completely flying blind. There is no textbook for what was happening in Yambuku.
Well, welcome to our deep dive into the source material that chronicles this exact harrowing chapter in human history. We're looking at a really substantial stack of sources today.
We've got everything from contemporaneous New York Times reporting to highly detailed, peer-reviewed retrospective papers in the Journal of Infectious Diseases.
Yeah, so our mission today is to explore this devastating 1976 epidemic. We're looking at the incredible toll it took on the people who simply tried to care for the dying. And of course, the seasoned, veteran virus hunters who risked their lives to track it down, contain it, and ultimately name it.
And for those of you listening who followed our previous deep dive into the Machupo virus in Bolivia, you're going to immediately recognize the key players here.
Oh yeah, this is the direct sequel.
It really is. We are tracking the exact same American scientists. Dr. Karl Johnson, the virologist who isolated the Machupo virus, and Dr. Patricia Webb.
Right. She was a highly skilled career U.S. Public Health Service laboratory virologist and also Johnson's partner.
Right. We're going to examine how the very hands that broke a Bolivian hemorrhagic fever carried their specialized expertise out of the South American jungles and directly into the African hot zones.
But, to understand how we get from a rodent-borne virus in Bolivia to a massive international response in Central Africa, we can't just skip ahead to 1976.
Oh, the context is too important.
The connection isn't just geographical. It's a forced, rapid evolution of laboratory capability. The sources show us that we actually have to start 7 years earlier, in 1969, with the emergence of a pathogen called Lassa fever.
Lassa is the critical precursor here. I mean, it is the terrifying warning shot that basically forced the United States to completely rethink how it handled lethal viruses.
So what happened in '69?
Well, in 1969, American missionary nurses working in a village in Nigeria called Lassa fell ill with this really severe, mysterious hemorrhagic fever.
And they sent samples back home, right?
Yeah. Blood samples from these nurses were eventually shipped back to the United States for analysis. Specifically, they went to an elite laboratory at Yale University.
Which was directed by Jordi Casals.
Right, Jordi Casals, who was a titan in the field of arbovirology. But the sources reveal a pretty terrifying sequence of events once those samples arrived.
Because Yale wasn't ready for it?
Not at all. Lassa virus bypassed Yale's standard laboratory safety protocols entirely.
Yeah.
I mean, Lassa isn't like working with a common cold or even polio. It is incredibly virulent.
And the really scary part, it can aerosolize easily in a lab setting, right?
Exactly. That's the kicker. If you are spinning a sample in a centrifuge and, say, a glass tube breaks, or if you are just pipetting fluid and you create a microscopic splash, the virus basically becomes suspended in the air.
Which is a nightmare.
A total nightmare. And the consequences of that exposure at Yale were catastrophic. A technician working in the lab contracted the virus and survived, but only after a grueling, life-threatening illness.
Jeez.
But then a visiting researcher, Juan Roman, he contracted the virus and died.
Wow. So it's this fundamental mismatch of infrastructure to threat. trying to contain a hemorrhagic fever with 1960 standard lab protocols. I mean, it's essentially like trying to contain a gas leak with a chain link fence.
That's a perfect way to put it. The hazard just drifts right through the physical defenses.
So the sources show that the reaction was immediate and drastic. Yale University completely halted their research.
Shut it all down.
One of the premier scientific institutions on the planet just walked away from the virus because it was simply too dangerous to even look at.
They had no choice. They recognized that without specialized high-containment infrastructure, which practically did not exist in the civilian sector at the time, every single experiment was a roll of the dice with human lives.
So Yale halting their research leaves this massive void in global public health.
A huge void.
But wait, I have to challenge the standard narrative here for a second. We often frame the subsequent government response as this heroic moment of stepping up. But isn't it actually a profound systemic failure that the U.S. government waited until elite scientists at a premier American university were dying to take these fevers seriously?
What?
I mean, why wasn't an outbreak devastating Nigerian villages enough of a catalyst to build high-containment infrastructure beforehand?
That is the uncomfortable, undeniable reality of public health history. Funding, infrastructure, and political will almost always follow domestic panic, not distant suffering.
Right. It has to hit home first.
For decades, tropical hemorrhagic fevers were viewed by Western governments as isolated, distant problems. They happened over there. But Lassa fever shattered that illusion completely.
It proved that a virus from a remote Nigerian village could be loaded onto a commercial airliner, flown into a Connecticut laboratory, and immediately kill an American researcher.
Exactly. It wasn't until the threat crossed the border and bypassed the Ivy League safety nets that the U.S. Public Health Service realized their ad hoc, university-based lab system was fundamentally porous to these apex pathogens.
He needed a dedicated federal fortress.
Yes, they did. And the sources detail how, in 1972, following the Yale shutdown, 10 U.S. Public Health Service officers volunteered to take up the dangerous study of Lassa fever.
Wow. Volunteered.
Yeah. They moved the operation to a newly formed agency called the CDC, the Center for Disease Control, down in Atlanta, and they did this inside a maximum security laboratory.
10 people, stepping into a room to face an invisible entity that just shut down Yale.
It took guts. This crisis triggered a massive structural reorganization. Between roughly 1975 and 1977, Karl Johnson was brought in to build and lead the CDC's brand new Special Pathogens Branch.
Which became the institutional home for the deadliest viruses on the planet.
Right, consolidating the United States' high-containment expertise under one roof. Think about the engineering required for this place. Negative air pressure systems, so air always flows in, never out.
So the virus can't escape if a door opens.
Exactly. HEPA filtration to scrub the exhaust air. Positive pressure suits for the scientists. It is a completely alien environment.
And Patricia Webb was right there too, bringing her incredible expertise in characterizing dangerous viruses into this new high-containment world.
She was absolutely instrumental.
So basically, because of the hard, tragic lessons of Lassa, by 1976, the United States finally had a specialized unit ready.
And they were about to face a test that would push that new infrastructure to its absolute breaking point.
Okay, let's unpack this. Because the ultimate test for the Special Pathogens Branch didn't just come as a single spark in the forest. It came as a twin eruption.
Yeah, we are moving into the autumn of 1976 now. And the geography here is just staggering. A catastrophic bleeding fever erupted almost simultaneously in two incredibly remote places.
And they were separated by about 1,000 kilometers of dense equatorial terrain.
Right. To put that distance in perspective for you listening, that is roughly the distance from New York City to Detroit or, London to Berlin.
Location number 1 is in northern Zaire, what we now know as the Democratic Republic of the Congo. Specifically, it was centered around that Belgian Catholic mission hospital we mentioned earlier in the village of Yambuku.
Right, and then location number 2 is far to the northeast in southern Sudan. This outbreak was centered in the cotton and cloth manufacturing towns of Nazara and Maridi.
Let's look closely at what this fever actually did to the human body, because the contemporaneous New York Times reports from October 1976 are chilling. When we say bleeding fever, we really need to understand the cellular mechanism.
It's brutal.
Hemorrhagic viruses, like the one emerging in Zaire and Sudan, directly attack the vascular system. They target the endothelial cells, right?
Yeah, and those endothelial cells form the vital inner lining of our blood vessels.
So what exactly does the virus do once it gets there?
Well, the virus replicates inside these cells and essentially causes them to detach from one another. It makes the blood vessels physically porous, so fluid and blood literally begin to leak out into the surrounding tissues.
Just microscopic leaks everywhere.
But it's worse than just leaking. At the same time, the massive viral replication triggers an overwhelming inflammatory response, what we often call a cytokine storm.
Right. The immune system panics.
Exactly. And this massive inflammation rapidly consumes all the body's clotting factors, which leads to this paradoxical condition called disseminated intravascular coagulation, or DIC.
Wait, paradoxical how?
Because your blood is simultaneously clotting uncontrollably in the microscopic vessels of your organs, choking off oxygen, while you are hemorrhaging freely from your eyes, nose, gums, and injection sites.
Because you have zero clotting proteins left for the actual bleeding.
You got it. It is a dual systemic assault. And it leads to rapid hemorrhagic shock and multi-organ failure.
God, the speed was terrifying. The New York Times tracked the chaos back then. They were reporting 150 dead, then 230, eventually noting a toll of roughly 335 across both countries.
But the reality on the ground was likely much, much higher.
For sure. And what is so deeply heartbreaking about the sources provided is how the disease was actually spreading. It wasn't primarily spreading through the air like influenza.
No, it wasn't airborne like that. In Yambuku, at the Belgian mission hospital, the spread was amplified mechanically. And tragically, it was amplified by standard medical practices of the time and place.
We really have to put ourselves in that clinic to understand it was severely under-resourced. The nurses were treating hundreds of outpatients every single day.
People coming in for malaria treatments.
Right. Pregnant women coming in for prenatal care, workers getting routine vitamin injections, and the entire hospital was operating with just 5 glass syringes.
Let that sink in. 5 syringes for hundreds of patients.
Between injections, the standard practice was often just a quick rinse in a pan of warm water, not the rigorous, prolonged boiling required to achieve true sterilization.
It's devastating to think about. The very instrument meant to heal the syringe was acting as a direct mechanical vector. It was injecting the virus directly into the bloodstream of patient after patient.
So a woman comes in for a simple vitamin shot and leaves with a lethal hemorrhagic fever.
Yeah, that was the mechanical amplification. But the sources highlight another, even more profound form of transmission: human amplification. The disease spread intimately through the act of caregiving and mourning.
The sources specifically ask us to honor the fallen caregivers, and it is vital we do that. We are talking about local villagers washing the bodies of their loved ones to prepare them for burial.
Right.
We are talking about dedicated local Zairian and Sudanese nurses who stayed at their posts even as their own colleagues died. A heroic Sudanese physician in Maridi, the Belgian missionary sisters in Yambuku.
It's incredible bravery, because the safest possible protocol when a hemorrhagic fever breaks out is absolute, strict isolation. You do not touch the sick. You do not touch the dead.
But human nature, culture, and the specific vocation of medicine compel people to do the exact opposite.
Exactly. Think about the psychological reality of being a nurse or a family member. Your instinct is to comfort the sick, to bathe their feverish skin, wipe away the blood, hold their hand as they die.
The very act of seeking medical help, the profound cultural duty to honor the dead, and the compassionate act of nursing care, those were the primary pathways for the virus. Their empathy was literally weaponized against them.
It is the ultimate tragedy of care. Now, while the devastation in Zaire and Sudan looked identical to the terrified people on the ground, the sources point out a critical scientific nuance regarding the virus itself.
Oh, right. The strains.
Yeah. Modern genetic analysis later revealed that the outbreak in Zaire and the outbreak in Sudan were actually caused by 2 distinct strains of the virus.
What we now classify as Ebola Zaire and Ebola Sudan.
Right. The case fatality rate for the Zaire strain around Yambuku was astronomically high, approaching 90%, making it one of the most lethal pathogens ever recorded.
Wow.
The Sudan strain was slightly lower, hovering around 50%, though obviously still devastating. But in the autumn of 1976, the scientists flying into these hot zones didn't have modern genome sequencers.
So they treated the twin eruptions as a single, terrifying, emerging disease.
Exactly. Imagine being dropped into that environment. You are a scientist arriving in a remote village. The local hospital is completely paralyzed. The nurses are dead. The missionaries are dying. The villagers have fled into the forest out of sheer terror.
How do you even begin to fight a monster that actively targets and kills the doctors?
The answer lies entirely in the laboratory skills that Karl Johnson, Patricia Webb, and their colleagues had spent years honing, from the jungles of Bolivia all the way to the high containment labs of the CDC.
Let's track the international mobilization here. On October 6, 1976, the World Health Organization officially mobilized and sent medical teams to both Zaire and Sudan.
And back in the United States, the CDC's head of viral diseases was desperately trying to build a differential diagnosis based on the early fragmented reports coming out of Africa.
I mean, what could cause bleeding, high fever, and rapid death in equatorial Africa? The initial suspect list was pretty logical, right?
Yeah, it was yellow fever, Marburg virus, and of course Lassa fever.
But the serological testing on the early samples showed it wasn't Lassa. And it wasn't yellow fever either.
No. And what's fascinating here is how the actual identification of the virus unfolded. Popular culture loves the myth of the lone hero scientist peering into a microscope and having a eureka moment.
Like in the movies.
Right. But the 1976 discovery was a plural, highly collaborative global effort.
The sources make this incredibly clear. The agent was identified almost simultaneously as a brand new virus belonging to the Marburg family by a network of laboratories working around the clock.
You had the CDC in the United States, the Specialized Porton Down Laboratory over in the United Kingdom, and the Institute of Tropical Medicine in Antwerp, Belgium.
Where a brilliant young microbiologist named Peter Piet was looking at samples sent in, like a thermos, right?
Yes, literally a thermos. They put the samples under electron microscopes and saw these bizarre filamentous shapes, like a shepherd's crook or a twisted thread.
So it looked like Marburg, but it was biologically distinct?
Exactly. It was a new filovirus.
Meanwhile, on the ground in Africa, you have this incredible international cast of characters stepping into the hot zone. Joel Bremen, a CDC epidemiologist, Peter Piet flying in from Belgium, and U.S. leaders fielding the response like William H. Fooge and John A. Bryan.
But while these men are flying into the jungle, navigating the incredible physical danger and political complexity on the ground, the sources point us towards someone else.
Patricia Webb.
Right, someone whose work was unsung, entirely unglamorous, yet absolutely decisive to the entire operation. Dr. Patricia Webb.
She didn't deploy to Zaire, did she?
No, she stayed in Atlanta, sealed inside the maximum security lab of the Special Pathogens Branch. And her work was the anchor for everything happening in the field.
Let's really do a deep dive into the actual laboratory technique here. Because this is how the invisible becomes visible. What was she actually doing in Atlanta that was so critical for the teams sweating in the jungle?
Well, identifying the physical shape of the virus in an electron microscope in Europe that doesn't tell the epidemiologists in Africa who is infected, who is immune, or how far the disease has spread into the surrounding villages.
To know that, you need serology.
Exactly. Webb was preparing and supplying the field teams with antigen-coded slides to perform an immunofluorescence assay, or IFA.
We need to explain exactly how monumental a task this is. How do you safely prepare a lethal hemorrhagic fever virus to be shipped back to a jungle field hospital for mass testing?
It requires meticulous precision. First, Webb had to grow the live, highly lethal virus in tissue cultures inside that maximum containment lab.
Which is terrifying on its own.
Oh, absolutely. Then she had to completely inactivate it. This is usually done using gamma irradiation or specific chemical fixatives like formalin.
So the goal is a delicate balancing act, right?
Right. You have to completely kill the virus so it cannot replicate and infect the field workers, but you must perfectly preserve the physical shape of the viral proteins, the antigens, on its surface.
You are basically creating viral husks.
That's a great way to describe it.
Yeah.
Dead, but structurally intact. She then affixes these inactivated viral husks onto tiny glass microscope slides. She essentially built custom, high-tech testing kits in Atlanta and shipped them on ice to Central Africa.
So when the epidemiological team in Zaire walks into a village and takes a blood drop from a terrified resident, what is the exact mechanism of the test?
They take that blood sample and separate the serum. If that villager has been exposed to the virus and survived, their immune system will have generated specific antibodies.
And antibodies are proteins with highly variable regions designed to lock onto specific foreign shapes.
Right. Like a specific key fitting into a highly specific lock. They watch the patient's blood serum over Webb's prepared slide. If the specific Ebola antibodies are present in the serum, they physically bind to the viral husks anchored on the glass.
But antibodies are microscopic and invisible. How do you know they are attached?
That is the genius of the immunofluorescence assay. After washing away the rest of the serum, they apply a second solution. This solution contains a different type of antibody that has been artificially attached to a fluorescent dye molecule.
Okay, and this secondary antibody is designed to bind to human antibodies.
Yes. Exactly. So it stacks.
The viral husk is on the bottom, the patient's antibody binds to the husk, and the glowing dye antibody binds to the patient's antibody.
You got it. You wash the slide one more time to remove any unbound dye. Then, you place the slide under a specialized microscope equipped with an ultraviolet light source.
And what do they see?
If the patient had the antibodies, the ultraviolet light excites the dye, and the viral particles glow a bright, unmistakable apple green against the dark background of the slide.
Think about the logistics of pulling that off in rural Zaire in 1976. I mean, they didn't have a pristine climate-controlled lab.
Not at all.
They were running portable generators to power the UV microscopes. They were sitting in stifling equatorial heat, wearing heavy protective gear, peering through a lens looking for an apple green glow.
It's heroic work. Those slides from Webb were the only map they had. Without them, they would be completely blind to the true scale of the epidemic. They wouldn't be able to track the chains of transmission at all.
So Webb serology was really the absolute bedrock of contact tracing. And through this massive interconnected effort, the epidemiologists tracing contacts in the villages, the global labs confirming the morphology and Webb processing the serology, they finally isolate and understand the agent.
Right. It is undeniably a new virus.
Which brings us to a seemingly simple question, but one that carries massive, long-lasting weight for everyone involved. Once you have isolated a monster, once you've isolated it, what do you name it?
It is a profound ethical dilemma. Because in epidemiology, a name isn't just a scientific label for a journal article. It carries deep social, economic, and political consequences for the real human beings living at ground zero.
To truly understand the stakes of this naming process, we have to look back again at Lassa.
Right. Remember, Lassa fever was named in 1969 directly after the specific Nigerian village where the first recognized cases occurred.
And the consequence of that decision for the people living there was just devastating. Naming a lethal, horrifying disease after a town fixes a permanent, insurmountable stigma on that place and its people.
It's inescapable.
For years afterward, the people of Lassa faced intense discrimination, fear, and economic isolation. Imagine trying to trade goods or travel or get a job, and the moment you say where you are from, the person across from you recoils in terror. The village became synonymous with a plague.
Which brings us to late 1976. Karl Johnson is now acting as the scientific director of the International Commission.
He is working out of Kinshasa, the capital of Zaire, right?
Yeah, trying to manage the vast logistical response to the Yambuku outbreak. And the time comes to give this new filovirus an official name. Johnson acutely knows the history of Lassa. He lived through it.
He knows that the Belgian mission hospital in Yambuku and the villagers surrounding it have already suffered unimaginable physical and psychological trauma. The nurses are dead, families are decimated, the survivors are completely traumatized.
Exactly. So he sits down, looks at a map of the region, and makes a quiet, deliberate, and deeply ethical choice. He decides to spare the village of Yambuku from becoming a global synonym for death.
He looks past the village. He searches the map for a geographical feature that is close enough to be scientifically accurate for the historical record, but distant enough to prevent direct, localized stigmatization.
He proposes naming the virus after a river located some 60 kilometers away from Yambuku, the Ebola River.
Ebola River.
Yeah, and the sources delve into the linguistic roots of this, which is incredibly profound. The river's name, Ebola, is actually a French adaptation of the local Mbandi word, legbala.
And the translation of legbala is white water or pure water.
Yes.
Pure water. I mean, the absolute tragic irony of naming a disease that causes catastrophic, uncontrollable hemorrhage pure water. It is a staggering contrast.
It really is.
But as a piece of epidemiological policy, it's fascinating.
Mm-hmm.
But I have to ask, does naming it after a river 60 kilometers away actually stop the stigma? Or does it just shift the geographical burden to a different set of people?
Well, it creates a necessary buffer. A river moves. It flows across vast territories. It doesn't have a single fixed zip code of inhabitants to ostracize.
That makes sense.
While it doesn't entirely eliminate regional stigma, it fundamentally dilutes it. If we connect this to the bigger picture, Johnson's decision represents a massive evolution in public health ethics.
Because before 1976, diseases were routinely named after specific places, right?
Right.
The Spanish flu, Marburg virus, Lassa.
Exactly. Johnson's choice was a formal acknowledgement by the scientific community that the socio-political impact of an outbreak can be as dangerous to a community's survival as the virus itself. It established a new moral precedent. First, do no harm, not just biologically, but socially.
It is a small act of conscience executed inside an overwhelming catastrophe. And it perfectly transitions us to the broader historical legacy outlined in the sources.
Because the successful naming, investigation, and eventual containment of the 1976 outbreak didn't just end a single epidemic, it forged a permanent template.
It absolutely did. 1976 was the crucible that wrote the modern playbook for global outbreak response. If you look at how the world handles terrifying pathogens today, the steps are almost identical to what was improvised, tested, and codified in Zaire and Sudan.
Let's run through the pillars of that playbook. Pillar 1, rapid international deployment. You don't wait for the host country to request a specific specialized test. You put multidisciplinary teams of epidemiologists, logisticians, and clinicians on planes immediately.
Pillar 2, maximum containment laboratory identification. You establish a secure, fast cold chain pipeline from the jungle hot zone directly to a specialized facility like the CDC's Special Pathogens Branch to figure out exactly what viral family you are fighting.
Right. Pillar 3 is perhaps the most crucial for saving lives on the ground. Barrier nursing.
This was the painful, bloody lesson of the Yambuku mission hospital.
Exactly. You must implement strict infection control. That means full protective gear gowns, gloves, masks, goggles. It means relentless sterilization using bleach and incineration. It means strict physical isolation of the sick.
You have to prevent hospitals from becoming amplification engines.
You must protect the caregivers first, because if the medical staff falls, the entire public health system collapses.
And Pillar 4, outbreak containment built on rigorous surveillance and contact tracing. That is Patricia Webb's antigen slides, allowing the teams to meticulously track every single person who interacted with a patient, monitor them for 21 days, and isolate them the moment their temperature spikes.
Yep. If you look at the lineage we have been tracing across these deep dives, from the foundation of the Epidemic Intelligence Service to the MARU lab in Bolivia fighting Machupo, leading right to Karl Johnson and Patricia Webb in 1976, this moment is the global zenith of that lineage.
This was American public health science, operating at the absolute forefront of the world's response to a novel plague.
It was arguably their finest hour. But there is a profound institutional twist here that the sources highlight, and it's essential for understanding modern global health.
Right. While the Americans were undeniably brilliant, while they brought unmatched laboratory capability and hardened field experience, their power in Zaire was not absolute.
No, they didn't march in wearing hazmat suits and take over the country.
Exactly. Their power was entirely investigative and advisory. Johnson, Webb, Bremen, Foge. They didn't command the operation. They worked under the diplomatic and organizational umbrella of the World Health Organization.
And crucially, they worked alongside Belgian microbiologists like Peter Piot, and alongside Zairean and Sudanese medical professionals who were risking their lives in their own countries. It was a true model of collaboration over command.
That is a huge distinction. And there's another layer of irony regarding the institutions themselves. All of this brilliant world-saving capability, the Special Pathogens Branch, the rapid response teams, the serology labs, it was all housed in the CDC.
Which was the offspring agency.
Right. While the CDC was ascending to unprecedented global prominence and prestige, its parent agency, the venerable U.S. Public Health Service, was simultaneously facing severe budget cuts,
Closing its own historic hospitals.
and shutting down its overseas research laboratories. The lineage of American field epidemiology had never been brighter, it had never been more clinically effective, but it no longer lived at its original home. The torch had permanently passed.
The 1976 Ebola response proved that the future of public health wasn't going to be driven by a single, monolithic national agency dictating terms from Washington. It was going to require specialized, highly trained federal units that were willing and able to plug into a decentralized, collaborative international network.
It's incredible to zoom out and look at what a single generation of scientists accomplished. We watched Karl Johnson and Patricia Webb carry their hard-won expertise from the remote, humid jungles of South America through the terrifying crucible of the Yale Lassa fever incident into the massive engineering feat of a maximum security lab in Atlanta, and ultimately into the devastating African hot zones of 1976.
They didn't just survive. They left behind a modern preventive playbook for humanity's survival against emerging viruses.
And amid all the clinical data, the electron microscope photographs, and the overwhelming tragedy, they left behind a name Ebola chosen out of pure empathy for a suffering village.
Which raises an important question, and it is something I think is vital for you to reflect on today. In 1976, American public health reached its absolute peak of effectiveness, not by taking charge and issuing unilateral orders, but by adopting an advisory, deeply collaborative role.
Yeah?
They provided essential laboratory tools from afar and worked humbly under an international umbrella alongside local experts. So, in a modern world that is increasingly focused on hardening national borders, centralizing command, and going it alone, does the success of the 1976 Ebola response suggest that humanity's greatest defense against invisible threats actually relies on relinquishing ultimate control in favor of global, humble collaboration?
That is a really powerful thought to leave on. When the diagnostic landscape gets murky, when the borders blur and the pathogen is moving silently through the community, maybe precision doesn't come from a single microscope. Maybe it comes from a global network of people willing to share the lens. Thank you so much for joining us on this deep dive into the source material. We hope this exploration of the history that shapes our modern world keeps you curious. Stay safe, keep asking questions, and we will catch you on the next deep dive.